initiated it. Just a minute, sir.
Just give us a 3, 2, 1, okay?
Yeah, sure, sir.
Who's introducing?
Sir, we are streaming live now. Yeah.
Okay, we can start, sir.
Yeah,
Yes, sir.
Should we start?
Yeah, please, sir.
Should I start?
Yes, sir.
Yes, sir. Please introduce our guest for the evening, sir.
Sir, I welcome you. I welcome you all to this video teaching program, Chapter 4. Our speaker today is Dr. Rajesh Sinha. Whenever there is a complication during surgery or the case is difficult, Dr. Rajesh is always remembered or he's called. And he handles the case so well that the same case, he will talk about IOL implantation during in difficult situations. And now I'll ask our dynamic secretary, Dr. J.S. Bhalla, to start the proceedings and proceed.
Thank you so much, sir. Yeah. This is the fourth in the series of DOS video teaching program. We have had very successful 3 earlier video teaching programs. And I just have the honor of introducing our speaker of the day, Professor Rajesh Sinha. Professor Rajesh Sinha is Professor of Ophthalmology in Corneal Lens and Refractive Surgery Services at RP Center, All India Institute of Medical Sciences. He's done also his MD Ophthalmology from AIMS and then DNB, FRCS, and did a fellowship at University of Washington. He has 364 publications, 4 textbooks, and 5 educational manuals to his name. He has been a part of 3 multicentric FDA clinical trials, has received various awards, notable among which are Achievement Awards of American Academy of Ophthalmology, APAO, and SARC Academy of Ophthalmology, and has been appointed the Professor of the Asia Pacific Academy of Professors in Ophthalmology. He is also recipient of many notable positions in the country. He is currently the Treasurer of All India Ophthalmic Society, Treasurer of SARC Academy of Ophthalmology, and General Secretary of Indian Society of Cornea and Keratorefractive Surgeons, and also Treasurer of Eye Bank Association of India. We are privileged to have you with us, sir. And so the topic for the day is IOL lens implantation in difficult situations. I'll now hand over to Dr. Praful Maharana to moderate the session, and please invite Dr. Rajesh Sinha for delivering his talk.
Good evening, everyone. I think we have a lot of participants today, and few people are requesting through SMSs also, please let us join. We are working on that, but we'll have to start the session now. Dr. Rajesh, please, as you have been teaching us since years, especially me. So please, you can start your presentation. And
thank you. At the outset, I would like to thank the DOS executive led by the President, Dr. Pawan Goyal, Secretary, Dr. J.S. Bhalla, very dynamic Dr. Jatinder Bali, Dr. Alkesh Chaudhary, and of course, our own dear Praful Maharana, who is very much into academics. I really thank you all for giving me this opportunity to share my opinion with you all. So I'll just open my, Okay, so I'll be discussing about IOL implantation in complicated scenarios, in challenging scenarios. There are many situations. We all know that IOL implantation is the standard of care for visual rehabilitation of aphakia. And am I audible clearly?
Yeah, you are audible and the slides are clear.
Okay, fine, thank you. Please let me know if there's any internet glitch because I'm traveling. So I'll be discussing about some unique scenarios, some difficult scenarios wherein we do have to implant intraocular lens in order to provide the outcome. I don't have any financial interest. Now, the first scenario that I'll be showing to you is a case of corneal perforation repair. It's a corneal scar which is in the periphery. Now, whether we should implant causing a lot of astigmatism. Now, this patient having little bit of zonal dehiscence here. Now, whether we should implant a toric IOL in this or not, that's a question mark. Now, the point is that this is a scar which is there for last 12 years. It is stable and the keratometry is more or less the same, but causing a lot of astigmatism. And even if we do a cataract surgery, place a spherical implant, the patient will still require a cylinder in the glass. So we thought that we should do a toric implant. Now, if there is an opacity or scar in the center of the cornea, we should never implant a toric IOL. But if this opacity or the scar is in the periphery and the limbus, we can go ahead and do it. Now, so the marking is done as we do for any implant. So we'll move on with this. And once the axis is marked, then the cataract procedure has been done, the emulsification has been done. Now, here I'm putting an capsular ring. You can see there's a little bit of zonal dehiscence here. So, small area of zonal dehiscence, which is stable, which is post-traumatic, which is not going to progress, therein we can safely place CTR and put a toric implant in such a scenario. And this patient responded very well. So this is one example wherein we can put a toric implant. Now, another scenario, a case of a operated DAL, a 56-year-old male who was operated for DAL for keratoconus, and now he is having cataract and he requires an iron implantation. So in such a case, who is a 56-year-old having operated DAL, which is hopefully, which is clear and which is not going to fail, most probability, in such a case, we can place toric IOL. So toric IOL in such a case, if it was a 24-year-old boy, I would hesitate in putting a toric implant. But this was a 56-year-old male, and plus it was not a full thickness graft, it was an anterior lamellar graft, and the risk of rejection will be minimal because the surgery was done 7 years back. So all this, taking all these into account and to take care of the astigmatism, a toric implant has been put. Another scenario, a case of a megalocornea. Now, in a megalocornea, what will happen? Large cornea and the bag is also large. In such a case, having primary astigmatism, how will we place a toric implant? Because the patient is not willing to use contact lens, not willing to use cylinder in glasses, requesting for something to be done. So in such a case, we may implant a toric IOL. However, the idea is this, the point is this, that the capsular axis should be lesser than 5 millimeter, something around 4.5 millimeter. And the IOL has to be placed in axis, and then reverse optic capture should be done. Now you can see the IOL has been placed in its position in the bag. Viscoelastic has been removed completely from the front and from behind. And then a reverse optic capture is being done. Now this reverse optic capture will prevent the IOL to rotate because the bag is large. In such a case, if you place a toric implant, the implant will rotate in the post-op period. So to prevent rotation of implant, you can see the IOL has been aligned in position and then reverse optic capture has been done. And keeping this in mind, a capsular axis of 4.5 millimeter was done so that reverse optic capture can easily be done. Another scenario, a case of a microspherophakia. In such a case, surgery should be done as early as possible. Sometimes these patients, because of high myopia, and if a microspherophakia is not detected, I have encountered a couple of patients coming to my OPD who have been operated LASIK for myopia, which was due to microspherophakia. So a good examination, evaluation of the patient is must. Even if the lens is clear, you have to see if the patient is having high myopia, the pupil should be dilated, and once you dilate, you will get to see. Now, in this case, you can see the reflection of light, the trans illumination is there, which is showing that this is the margin of the crystalline lens. So in such a case, you have to judge. Now in a microsphericalgia, you can have various spectrum of cases. Now here, the lens is in position. It is not coming into anterior chamber, not subluxating too much. So in such a case, you can manage by placing an endocapsular ring, stretch the capsular bag, and then place an intraocular lens. So in this case, after doing the complete cortical aspiration, an endocapsular ring is being placed. Now, if this lens was too badly subluxated and would not have been in position, coming into anterior chamber, I have done a couple of lens removal with intrascleral haptic fixation in such a case. But in a case of a microsphericalgia wherein the bag can be stabilized with endocapsular ring, nothing like it, because that is the most physiological situation. IOL in the bag is something that we all desire, and that could be done in such a case. Now, with subluxation and with the lens not in position, I will move to a different spectrum of cases. Now, this is a case wherein there is zonal dehiscence for about close to 120 degrees, 100 degrees. Now, in a 100-degree subluxation, you can manage with endocapsular ring, provided the subluxation does not increase more during the procedure. And for that, you should use a lens hook. In this particular case, could not get a lens hook, so I've used an iris retractor to stabilize the capsule, but it is a bit risky. It is always better to use a lens hook in such a case to stabilize the capsule in that position. Go ahead, complete the nuclear emulsification, remove the cortical fibers completely, and then you try to estimate how much is the subluxation. You can see that the subluxation has not increased, the zonal dehiscence has not increased significantly during the procedure. So an endocapsular ring is the best choice in such a case. And the endocapsular ring has been placed in position, and now you can place an intraocular lens in the bag very easily and safely. For doing all these procedures, the parameters should be low. So everything should be on the lower side so that there's not much of turbulence. Now here it is a bit more of a subluxation, about 120 degrees subluxation, and this patient is a case of glaucoma as well, was requiring, might have required trabeclectomy. That's why superior part has been left, and the incision has been made from the temporal side. And after doing chopping and removing the cortical fibers by bimanual, in such a case, you should use a bimanual irrigation aspiration, and then Sione's ring is being fixed. So a single eyelet is being used because the subluxation is not much. So a single eyelet is being used to fix the Sione ring. And then once the 9-proline suture needle has been tied around the eyelet, then this endocapsular is placed in position, and then you tie the knot, and then you place the IOL. Now, in such a case, you should not try to dial the lens. Try to gently caress the haptic into the capsular bag, and that is useful. Now, in such a case wherein you have a subluxation of about 270, 300 degrees, in such a case, there is no point keeping, particularly in a child wherein there is progressive zonulopathy. In such a case, it's always better to remove the lens completely and do an intraocular haptic fixation of IOL. So the sclera is marked at 1.5 and 3 millimeter positions. The lamellar flap is being created, and the same is being done on the other side. And then with the help of intralentular aspiration, irrigation aspiration technique, what it does is that the irrigation cannula keeps the lens in position. It doesn't deviate further into periphery, and then you can aspirate with the aspirator, and then with the cutter you remove the capsule, and then with a lens fixing forceps, a multi-piece lens is being introduced here. Haptic is being exteriorized. The second haptic now is being exteriorized through the scleral stab incision, and then the haptic is tucked into the groove made adjacent to the flap on one side and both sides. And then with the help of fibrin glue, the flap is attached and the conjunctiva is also attached in position. Now, this is a case wherein one can plan a single eyelid Sione back fixation, and this is what I had planned. So a groove has been created at 1.5 millimeter position, and then stabilized the capsule with the hooks, and then went ahead with the phaco. But suddenly, by my mistake, there is a PC tear that has happened while picking up the last piece. In such a case, you cannot do a Sione's back fixation because it will stretch the tear, and the tear will increase. So in such a case, you what I will be doing is that the capsule is very much intact in this location. So if the same groove can be used for a one-sided fixation of scleral fixated IOL. See, this is a specially designed IOL with eyelet in the haptic. You can see the eyelet in the haptic. So there are eyelets in both the haptics, but only in one eyelet the suture will be passed, and it will be placed in this area where the capsule is not present. And then in this area where the capsule is intact, you can keep the haptic just like that over it. And as you can see here, it is being pulled, and then a knot is tied. Now you have to be very careful that you don't pull the knot very tightly. Otherwise, you will pull IOL on one side. That is the problem. And then once it is done, the conjunctiva is closed. A case of aniridia, traumatic aniridia basically. You can see here repaired corneal scleral perforation. Due to trauma, iris was completely lacerated, so it was removed. It was abscised somewhere. The lens had fallen back, so it was removed by vitrectomy procedure. And now the patient wanted, who is a medical student now, wanted to have a visual rehabilitation. So in such a case, an aniridic IOL is the best option. For aniridic IOL, you have to mark 9 millimeter because it's a rigid optic, and it is of 9 millimeter size. And it also has eyelet around its haptics, as you can see here. This is an aniridic IOL, 9 millimeter optic size with a 4 millimeter central clear cylinder. So knots are being tied around, it has been tied around one haptic, now has been tied around the second haptic, and then the needle has been exteriorized from the scleral groove. And initially the incision was smaller because of risk of collapse of globe. After that, it was increased to 9 millimeter size. A single knot is tied at the first place to titrate the tightness of and the centration of the IOL. Once you see the IOL is well centered, you can tie multiple knots and then close the wound. Now, this patient is really very happy and having a very good visual acuity. Now, coming to some other trauma cases. Now, this is a case wherein there was a trauma, perforating injury, which caused trauma to the lens. So the fluffy lens matter was there, so it was removed. Capsule was damaged. Now the patient had come for a secondary IOL. Now this patient, if you see carefully, there is a margin of anterior capsule here and a margin here. Posterior capsule is partly pacified, and the patient will not have good visual outcome unless you make a posterior capsular excess. So a posterior capsulorhexis has been made, and then the IOL is placed in such a way, as you can see here, that the one haptic lies underneath this capsular rim and the other haptic lies under this capsular rim. And this is, it is being placed. And you have a nice central opening, which will take care of the visual acuity, visual outcome of the patient. So once it is there, you can place a suture and then hydrate the wound. Another scenario, a case of a membranous cataract. Nothing, just a membrane with a large iridodialysis. You can see here a large iridodialysis and only a membrane all around. In center, there is a thick membrane. So in such a case, the best option is to do a iridodialysis repair and then place an intraocular lens, the most suitable one, whatever you feel at the time of surgery. So Sinha release is being done. There's some Sinha here. You can see after release of Sinha, 9-O-Prolene suture needle is introduced, and there's a large scleral groove that has been created opposite this dialysis so that multiple sutures can be passed. So one suture has been passed. Now the second suture again being passed. Then the third suture will be passed from here. And similarly, now here, sometimes what happens that the iris gets a little folded. So you have to stretch it also so that the iris doesn't get trapped into the next bite. So this is what you have to keep doing. And once you have done it, you tie the knot in such a way that the edge of the iris tissue only opposes. Otherwise, it will pull the iris tissue too much. And once you have done it, then you can create an opening with a cutter, and a multi-piece intraocular lens can be implanted in position. Once the multi-piece intraocular lens is implanted, you may put a suture so as to secure the globe, and then the knots are introduced inside the groove, and then with the help of glue, you can paste the conjunctiva. You can see this is a post-op picture, I think on day 7 or day 10, I exactly don't remember. But this is the post-op picture. You can see here, this whole iridodialysis has been well repaired. There's little bit of iris atrophy, and that is why there is some pull here, but still the IOL and everything is centered. You can't see any edge of the IOL, and things are reasonably all right. Another case scenario wherein it was a perforation that had happened, corneal perforation due to traumatic injury in a child. Iris was incarcerated. It was not released at the time of primary repair. So in that case, you have to cut flush with the cornea. Otherwise, you will cause iridodialysis. And then once you have done it, then you create a capsular opening, do a complete removal of lens matter, and there is a thick PC plaque over here. This PC plaque has to be removed, and once you have removed the PC plaque, you can see the visual axis is so much clear now, and then you can place an intraocular lens. Another scenario wherein traumatic total cataract with an iridodialysis, in such a case, you have two options. You do Sinha release, and now in such cases, I prefer putting an iris hook to pull the iris tissue first. Now, in that case, it was a membranous cataract, the earlier one. That is why I did the iris repair first. But if you have a total cataract when the lens is thick, in such a case, it's always preferable to go ahead and do the lens surgery first and then do the iris repair. Because the lens is thick and it pushes the iris tissue and it will be difficult for you to repair the iododialysis. So once this has been done, you can do the iododialysis repair and secure in its position. Another traumatic, post-traumatic cataract wherein there was a pre-existing defect, pre-existing posterior capsular defect. So in such a case, you have to be really careful. You have to be very careful in handling such a case. Don't do any vigorous hydroid procedure. And most importantly, if there is a trauma and there is a sudden increase in cataract formation, you should wait for 2 to 3 months' time for the margin of the capsule to fibrose. See, this is a posterior capsular defect. The margin has been fibrosed because we had waited for 2.5 months in this case. Now, while doing a removal of cortex, there was some vitreous that was coming, so vitrectomy is being done. You can see the fibrosed margin very clearly. And once the vitreous has been removed, again, with the help of a bimanual irrigation aspiration cannula, you can remove the cortical fibers. After all these maneuvers, you can see because of the fibrosed margin, the posterior capsular defect has not extended at all. So that is the advantage of waiting for some time so that your margin fibroses. And once again, in such cases, it is always better to gently caress the haptic to its position into the bag and not do a vigorous dialing so that you can prevent damage to the capsule further. Now, another case, a child wherein cataract surgery was done earlier and was left aphakic. In such a case, you can see the phimosis of capsule, both anterior and posterior capsule has been fused, so intracameral adrenaline is being put to enlarge the pupil, then visco enlargement will also be done. And then this fused margin is being separated and is being removed. And once you remove it, with the help of bimanual irrigation aspiration, you should aspirate out all the sommering ring. And once you have done that, you can do a little bit of anterior vitrectomy. And in such a case, wherein you can see the anterior capsule is so badly damaged and it is irregular, in such a case, it is always better to put a multi-piece lens and do an optic capture. So you can see here a multi-piece lens is being put. I'm sorry. It's being put and then the optic capture is being done. Optic capture is something which is a very good technique in order to have a good outcome, good stability of the intraocular lens. Now, in this case, since it was a child, I would like to enlarge this capsule as well. Optic capture has been done, but I'll still make a nick here and try to enlarge the capsule opening, because subsequently, if there is any phimosis, then I will not be in a position to do anything, because the IOL has been optic captured, and if there's any phimosis, if you do any significant manipulation, then in such a case, it is going to cause dislocation of the IOL. So you should clear it up at this point only, and then you can see here the visual axis is absolutely clear. Now, another scenario is cataract surgery in oil-filled eyes. It is again a very challenging scenario. There is high risk of complication due to residual effects of previous surgery. There is increased risk of post-op inflammation. There can be emulsified oil in anterior chamber. There can be presence of PC plaque. There can be presence of PC defect. And of course, there can be zonal dehiscence as well because of the long procedure. There can be fluctuating anterior chamber depth. There can be infusion deviation. And one thing I would like to tell everyone that, in a case of a vitrectomized eye, if you are doing a cataract surgery and the chamber is becoming shallow, be very careful. Don't increase the pressure of the anterior chamber. Don't raise the bottle height. Just thinking that the chamber is shallow, you have to do it. because infusion deviation is very much common in such cases. You should figure out the posterior capsular status and then plan surgery accordingly. So a case wherein silicone oil has been is still there, so cataract surgery is being done. So chopping technique is the best one. I'm sorry. The chopping technique is being done. So I'll just move fast. Now you can see here the reflection of the instrument because of the silicone oil. And there's a plaque which is fused to the capsule. And it is in the paracentral, it is in the slightly peripheral or paracentral region. So I will not touch the plaque. And I always prefer to put endocapsular ring in these cases, in operated VR cases, because of the long procedure, there is some zonal dehiscence in these cases. It's always better. There's no harm in further supplementing strength to the capsular bag. And in such a case, I will not do a PCC, because if I do a PCC, there will be the area of surgery, the operating field will become messy. And so that is why I will not do. And subsequently, this area is clear. If the patient can see better, can have a reasonably good vision, then we can just manage like that. Has to undergo a silicone removal in such a scenario, in such a case. At that time, we can make a small central opening, remove this plaque. But sometimes you can have a plaque which is separable. You can see here a thick plaque wherein you can create a cleavage plane. So once you create a cleavage plane, then you lift it with the help of the Sinha hook and with the help of a Utrata forceps, and remove this plaque and clear the visual axis and place the intraocular lens. Oil-filled eye, wherein a case of an oil-filled eye, wherein you can see there's a PC tear here. Now it is really a very interesting thing, because you have a PC defect while you're doing a vitrectomy, the cataract will progress very fast. But if it's an oil-filled eye, so oil will have a meniscus which will prevent passing any fluid through that posterior capsular defect. And that is why the cataract advances fast. Now, after doing all, removing the lens matter, you can see that coming from this PC defect. So in such a case, high viscosity viscoelastic, and then place a multi-piece lens. Now, after putting the multi-piece, if there is a oil bubble, I won't mind. I'll put a multi-piece lens and then do a optic capture. The haptic is in the sulcus and the optic is in the back. Once we do an optic capture, what happens that this optic seals the posterior capsular defect. No more oil that comes to the anterior chamber. And whatever oil is there in the anterior chamber, you can remove it. Another case, which is, this is the last segment that I'll be presenting, and I'll be showing to you 2-3 decentered IOLs. IOL that has been placed earlier, now decentered, how to fix them. Fix them with minimal manipulation. Now this patient has undergone a corneal perforation repair, lens surgery done, IOL was implanted, multi-piece in the sulcus. It is again moving on to this side. This means that there is a zonal dehiscence here. Now, in such a case, since I have got a nice large posterior capsular opening, the margins are fibrosed, following the principle of minimal manipulation, I will fix the IOL by doing an optic capture. So you can do an optic capture and the IOL can remain in position. So this is something which is very effective. Now you don't have to think about this area, the area wherein, I'll just show the area wherein there is a scar, because this patient can have a reasonably good vision from here. And subsequently, if the patient can undergo a penetrating keratoplasty, that will improve the visual acuity further. A case of nicely done surgery in the bag, implantation of IOL, minister by profession, had gone to a rally. There was some stone pelting, some trauma to the eye, and you can see the IOL haptic with the capsular bag in the anterior chamber. Now, since all these areas, zonules are fine, intact, so what I'm doing, following again the principle of minimal manipulation, putting an endocapsular ring from here so that it will stretch the bag, pull the bag behind the iris as it is being done here. And as you advance the endocapsular ring, it will pull the bag posteriorly and it will keep it in its normal physiological position. So a zonal dehiscence about 120 degrees or something, which can be managed by endocapsular ring, even if the IOL is there in the capsular bag, that is very much doable, and the IOL remains in position. Another scenario, IOL in the bag, but you can see there is so much of zonal dehiscence that it is not going to stay by endocapsular ring. Now, this patient had asteroid hallosis as well. So in this case, lasso suture is being planned. The single haptic fixation is being planned. So a groove has been created at 1.5 millimeter from the limbus. Paracentesis is done on the opposite side. A 9-O-proline suture needle is introduced to the scleral groove, passed under the haptic. We are seeing the capsule coming over the optic and then docked into the 26 gauge needle and then exteriorized. Now, in this case, in such cases, it is always preferable that whenever there is vitreous in the anterior chamber, you should remove the vitreous by vitrectomy before you do any further manipulation. So again, I have removed. Now, in this particular case, because of asteroid hallosis, I don't have to stain the vitreous. The vitreous is stained by itself. So once again, this needle is introduced back from the paracentesis over the haptic and optic, and then it is exteriorized to the scleral groove. Now again, I will remove the vitreous and then pull the IOL. So this lasso suture is being used to pull the IOL in its normal position. And you can see here, a single lasso suture has done the trick and the IOL is well centered. The last scenario, a reverse lens, which is there without any capsular support. I don't know from how this lens was there. This patient came to me with the history of repeated UGH syndrome, repeated inflammation. So I thought that it's better to place the IOL properly, and the IOL has been reversed. It is whenever you are reversing, it's always better to take out the haptic outside from the main wound so that the IOL doesn't fall. And then you grasp one tip of one haptic and then exteriorize the other tip as well, and then tuck it into the groove and stick the sclera as scleral flap as well as the necklace with the fibrin glue. Now, this patient was relieved of this UGH, and many times we do have a tendency not to do too much of manipulation, but sometimes patients who do require manipulation, we have to do. But again, placing the IOL in the correct position and in the correct orientation always helps in preventing such complication. So in conclusion, we can have various challenging scenarios wherein we have to place an intraocular lens. You all must be facing different type of challenges. You all must be innovating different ways of securing the IOL in its position, placing the IOL in its most physiological position as far as practically possible. For all that, it requires a good preoperative planning and careful and meticulous intraoperative manipulation. So thank you very much once again, the whole of DOS executive, for giving me this opportunity. I tried to keep it within the time limit and kept a few of the challenging scenarios. And of course, you all must be we all must have faced many more challenging situations and must have managed many more challenging situations in a much better way. So thank you very much once again.
Thank you so much, Dr. Rajesh. It was very wonderfully explained. The IOL implantation in almost all the difficult situations. You explained cases of corneal scar in center and periphery, and operated dark, megalocornea, microspherophakia, aniridia, then even in silicon filled eyes and decentered IOL with bag, where you should do optic capture, where reverse optic capture, and where lasso suture is used. I think, Praful, you can ask the panelists. We have panelists, Rajesh, from all over the country, and you will
For that, I would like to read one message. Somebody has written in the chat section. Thank you very much, Dr. Rajesh, sir. Yesterday was the last day of PG final year examination. Your teaching definitely are very useful. Thank you, sir.
So nice of you. I'm highly obliged for such a statement.
Yeah, and in spite of examinations of postgraduate in various parts of the country, we have very good attendance, both on this site and also on the YouTube. And it is really
great. Testimony, sir. That's the testimony of Dr. Sinha's popularity.
Dr. Bali, some comments from you regarding the presentation of Dr. Rajesh.
So this is a testimony of his popularity. Sir, like what would be your recommendations to the surgeons for subluxation and like how many clock hours, what procedure to do?
See, up to 3 to almost I would say up to 3 clock hours, yes, endocapsular is good. Then 3 to 6 clock hours, a single eyelet Sioni ring is good, or you can use segment as well with endocapsular ring. If it is between 6 to 9 clock hours, double eyelet Sioni's back fixation is essential. And if it's more than 9 clock hours, it's better to remove the lens in toto with capsule and do an intraocular haptic fixation or whatever technique you feel like, which will provide a good visual rehabilitation to this patient.
The reason why I asked this question was because, you see, everybody who's seeing this surgery doesn't realize that this is a master surgeon who's operating. And when you do have a subluxation, which is more than 4 or 5 clock hours, Dr. Sinha and these like the master surgeons can operate, just lower the parameters and then they carry on with it. But it's better not, you should know your limits and then probably explore. What you saw here was, something which is right. It requires special skills.
Yeah, I completely agree with you actually, because this is something which is recommended. This is something which we should do. But all these recommendations can be modified depending upon the expertise, depending upon the equipments that you have, depending upon what you are best at. So that is what is surgery is an art, and it takes the benefit of the science. So that is why so many innovations keep coming every now and then in surgeries. So I mean, all these modifications.
The other beautiful one that you've done. Sorry. The other beautiful one that you've done is that inversion that you've done. It's very beautifully done, sir. It is an extremely difficult procedure to attempt.
Yeah, for inversion,
inversion with the UGH syndrome.
Yeah, for inversion, you require 2 instruments. One instrument should be behind the IOL, and the second should be in front. And the moment you do that, you support the IOL with the one instrument, and then take out the haptic. You should make a main port before doing this inversion, so that you can exteriorize the haptic from the main wound. And then after that, you plan for fixing. Don't leave it there, because there was no capsule in that, and I'm still puzzled, and I still don't have an answer how the IOL was staying there. And that was a reverse IOL.
Yeah, Praful, you can take the questions of the panelists now. the residents
We have
and
taken few panelists from across India. One, Dr. Dhirendra has joined us from Bhopal. Dr. Dhirendra, you can unmute yourself and ask any question you want to ask, sir.
Yes, good evening, sir. Thank you so much. First of all, sir, it was a very informative seminar, and it's been very helpful for us throughout those conferences. I just wanted to ask if there is a post-RK patient, like the patient is post-radial keratotomy, and still we have to implant a toric lens, whether monofocal or multifocal. So how much of a refractive surprise should we expect, and should we even use sutures for that? Any change in the intraocular lenses, like we have to keep them? We order the lenses, and how much of a refractory surprise, or intraoperatively, how much of a change can we expect? So that is what I'm.
Dhirendra, you have asked a very difficult question. Yeah. Actually, in post-RK, you can have all sorts of surprises. Post-RK, what we have noted is that the astigmatism many times is irregular, and many times we are not in a position to place a toric implant. So more often, you will not be in a position to place a toric implant, because for toric implantation, you need to have a regular astigmatism and much of a scarring coming into the center, etc. Because many times these post-RK patients, they have multiple incisions, 16, 32, etc. There's irregular cornea. If it's a proper, like say 4 incisions done, regular astigmatism, in such a case, yes, you can still go ahead and do a toric implant if there is an astigmatism. But such scenarios are very less often seen in post-RK. More often, you are not in a position to place a toric implant. So whatever you can do, I mean, the best thing is that try to get the best possible IOL power. Obviously, all the nomograms that have been done, that have been made, they have been made based on LASIK. And in RK, the flattening effect is not the same as in LASIK. There is some degree of scarring as well. There's some degree of irregularity in the cornea as well. So whatever best way you can, try to get the best possible spherical power. And for any irregularity in the cornea, you can put place a RGP contact lens for best visual outcome. That is the most ideal scenario that I would say in majority of cases of post-RK cataracts. In a few cases, you may be in a position to place toric implants, wherein the astigmatism is regular. But they are very few.
Thank you, sir.
Thank you, sir.
Dr. Koel Chakravarti has joined us from Bhubaneswar. Dr. Koel, you have anything to ask to sir?
Good evening, sir.
Good evening.
Actually, I lost my connection in between. The presentation on subluxated cataract with iridodialysis. So how to go about it?
Yeah, actually, if you have a iridodialysis with a cataract, now I showed 2 scenarios. One wherein it was a membranous cataract. In such a case, repair the iridodialysis first and then do a membranectomy and put a multipiece IOL in the sulcus. That is one way. The second scenario is that you have a total cataract and an iridodialysis. In such a case, you better do a cataract surgery first. Try to release the synechia and stabilize the iris tissue. You can, I could not show you that video wherein I stabilized the iris tissue with iris hooks. The best thing is you put iris hooks in the area wherein you have a iridodialysis. Complete the cataract surgery. If there is some degree of zonal dehiscence, put an endocapsular. Complete the cataract surgery and then remove the iris hooks and then do the repair of iridodialysis. So that is how we should do. And repairing iridodialysis, I prefer using 9O proline suture, but people have used other sutures as well.
Thank you, sir.
Thank you, sir. So we have a few panelists joined as DOS VT Chapter 4. I can't see your name. Could you please unmute and ask your any questions you want to ask, sir, or any doubt you have? Dr. Manisha, you can unmute and ask anything you want to ask from Dr. Rajesh.
Do we have some sort of a chat box? If somebody has questions, there's that chat box. So please shoot the questions into the chat box.
Yeah, you can all please put your questions, or if not, you can ask the questions directly. Yeah, there is a question from Dr. Thori Prakash. He wants the concept of optic capture and reverse optic capture to be explained. He's has some confusion regarding that. Yes, Dr. Rajesh, can you explain for the benefit of the residents?
Yeah. See, the optic capture means that you place the haptic in the sulcus and capture the optic into the anterior capsular rim or anterior and posterior capsular rim both. Now, this kind of an optic capture is done in scenario as I had shown, like can you just a second?
Yeah.
I think we have a question from Dr. Dipali Singhal also.
Yeah. So, I was talking. I'm sorry for somebody came. So actually, what happens that if you're doing an optic capture, this means that the haptics are in the sulcus and optic is captured into the anterior capsular rim or both anterior posterior capsular rim. Reverse optic capture means that you have placed the IOL in the bag and then the optic is lifted up and captured into the anterior capsular rim. So that is reverse optic capture. So normal optic capture means that you are pushing the optic behind the capsule. And in reverse optic capture, you are pushing the haptic ahead of the capsule. That is what is optic capture and reverse optic capture. And I think there was one question in the chat box.
Similar to that, Dr. Dipali wants to know
Dipali,
that.
Yeah.
Do you recommend reverse optic capture in all high myopia cases? And what's your experience of toric IOL in high myopia patients? I think first part is confusing. We don't do reverse capture in all high myopia cases.
Yeah. Actually, as far as toric IOL is concerned, yes, it works well if there is any. Toric IOL is something which is very rewarding. And whenever there is any pre-existing astigmatism, we should put toric IOL because it is very rewarding. And it is it provides very good outcome. The second thing, what she mentioned is that do you do reverse optic capture? Sorry?
Just to add on to that, she may be asking about that high myopic cases where the axial length is around 30.
Yeah, the capsular bag is big and
the problem is this, that if you have a very high axial length, in that case, you cannot get a toric implant of that power. So in a very high axial length, you will not get a toric implant. Toric implants are not available in that high power, in such low power, actually, in such high axial length. That is the problem. And the second thing is, as far as reverse optic capture is concerned, I don't do reverse optic capture in myopes. I did a reverse optic capture in megalocornea because in megalocornea, the bag is large. And if the bag is large, then if you place the IOL, the toric implant moves because it is not snugly fitting into the bag. So in order to maintain its stability in one position, reverse optic capture was done in megalocornea. But in all high myopes, probably she means that the bag size will be higher, larger. In such high myopes wherein the bag axial length is very high and bag is also larger, we hardly get toric implants of that power.
It may be related to expandable series where you get that 3-piece length.
I think in expand series, we don't get toric implant to the best of my knowledge. Praful, do we get?
No, reverse optic capture in high myop cases where you have to inject a expand series IOL.
See, I personally don't do reverse optic capture in high myope. There is one reason why one can think of doing that is to reduce the risk of dysphotopsia in such cases.
Yeah. Yeah, it is also recommended as the treatment for negative dysphotopsia where the optic is broad
because the edge of these lenses are quite thick.
Yeah.
So that can be done to prevent dysphotopsia. To minimize, I would say, to reduce.
Mainly done for negative dysphotopsia, and as you mentioned, it can also be used for megalocornea where the bag is big.
Yeah.
But Rajesh, will it make any difference in the adjustment of IOL power also, because the optic is now placed slightly anteriorly? Do we need to maybe reduce the power by about 0.5 to 0.7?
Yes, 0.5.
0.5 diopter.
0.5.
Yeah.
So one more question is there about the use of ORA in operated corneal perforation cases. Is it useful and is it going to improve the visual outcome in such cases?
Well, ORA is something which is, yes, it is useful, but there is some element of error also in that. But yes, it can be used. It is something which has been used with good effect. We have been using it in repaired perforation as such. I have not used. I have used it in senile cataracts only. But in repaired perforation, maybe one can think of, because you are not sure about the keratometry and the astigmatism, etc. So that is a good idea one can think of. Only the thing is that
it may not capture. That may be an issue. If the scar is in the center.
Yeah. If the scar is in the center, then it may not capture. That is one issue.
Where exactly, what are the present day indications of intraoperative aberrometry in the present era? Where exactly?
Actually, in present era, whenever you feel that you have to do a refinement, I would say wherever you doubt that there can be some IOL power surprise, and even in routine cases, many times people do to have an absolutely accurate IOL power. So
we are not sure. That is a perfect statement by sir.
Sorry?
Any case where you are not sure your IOL power is perfect, you can use OR. This is what you said. Then I'm thinking that is the perfect statement.
Yeah.
Where you are not. Yeah.
You have to be doubly sure. You can make sure that your power is accurate. Many times, even in toric implant, you have implanted the put the toric implant, and then you do ORA after that. And then it will tell you whether any rotation is required or not. So there it will be written that no rotation required. So you are happy that, what I'm doing is correct and it is fine. Having said that, little bit of less viscoelastic in the anterior chamber, little bit of pressure, less or higher pressure can give some error in the values of ORA as well.
And you have to maintain the pressure around 25 millimeter of mercury to be able to get reasonably accurate readings, right?
Yeah. And you have to inject the viscoelastic to make it a bit on the tighter side, so that you get accurate reading.
There's a comment by Dr. Om Prakash. Do you feel usefulness of pupilloplasty during typical coloboma with cataract surgery?
Actually, I'm sorry, I should have shown that video. I had a very nice video of iris coloboma only. There is no retinal coloboma, iris coloboma only with cataract. And after doing the cataract surgery, I have made the pupil round by doing single pass 4-through pupilloplasty and passed 3 sutures and made the pupil round. So actually, I thought that it has not much to do with the IOL implantation. That's why I did not show that video.
So just to add one point to that, point of discussion maybe. So have you ever tried to enlarge the pupil? Because in IFC, what you have seen, the pupil is drawn towards one side. So few surgeons, they recommend you can enlarge the pupil little bit superiorly to give a visual access. So what's your take on that?
Yeah, actually, earlier I used to do that because that's what earlier I was told. So I used to make a nick superiorly, so that the idea was this, that the center of the IOL should be, the rays should hit the center of the IOL, and it may not get covered because it is a pear-shaped pupil which is a little directed downwards. So that was the basic idea. So what one can do now, earlier I used to make a nick, but now if in any case, if I make a nick, then I would like to put a suture down in the lower part, so that, if you are making it slightly superiorly, maybe I will not make a nick, I'll just trim it superiorly and suture it inferiorly. But having said that, if there is a case of a detachment or a doubtful retinal detachment, I will not do anything. In such a case, I will not suture the pupil, I will not do, because subsequently a vitreoretinal surgeon will in any case break that suture and he will curse me. So it is better to have an attached retina, and the patient should have some vision rather than making it circular or whatever.
Thank you, sir. Sir, there is one question about putting the timing of putting the endocapsular ring, CTR, which is often a point of debate. So whether you would like to put it before nucleotomy or after that?
I prefer, if it's a subluxated lens, I prefer to support the crystalline lens by supporting the capsule by capsule hooks. Okay. Sometimes iris hooks as well if I don't get a capsule hooks at that time. And then complete the nucleotomy and then put a endocapsular ring. If you have put the endocapsular ring, if you are aspirating the cortical fibers, you have to be absolutely tangential. Otherwise, you will pull the endocapsular ring in the center. These things one has to take care.
Your decision vary depending on the extent of subluxation?
Not for endocapsular ring. The decision, if the the subluxation is more, in any case, I will support it with the help of lens hooks. Go ahead and then plan for a fixation of the bag by Sioni ring or a segment, etc. But many people prefer putting endocapsular ring in mild subluxation in the initial part, immediately after, before the nucleotomy.
There's another comment by Dr. Om Prakash. Is central cornea normal in all optical aspects in colobomatous eye to harness the benefit of pupilloplasty?
Yeah, I think central cornea is mostly normal only, because it is the embryonic fissure that doesn't close, and that's why it results in formation of the iridofungal coloboma. This is what is the question, no? So the cornea is, sometimes the cornea is smaller in size, microcornea can be seen, but there is no opacity in the center in most of the cases. Rarely partial sclerocornea has also been associated, but it is very uncommon. Mostly it is the microcornea that is associated with the iridofungal coloboma. But the central part of the cornea is clear.
There's another question.
Remember, there used to be this debate. Okay. There used to be this debate that, you see, in a colobomatous eye, especially if it is beyond the age of plasticity, if it is beyond 10 or 11 years, then the visual apparatus is already used to the altered falling of rays onto the retina. So you simply replace the lens, and there was a huge debate that used to go on with whether we want to pull the pupil upwards or not. Probably that was what Dr. Om Prakash is alluding to.
Yeah, actually, you know what? That it is very difficult to say. A patient who is intelligent enough to understand that thing and tell us about it can only make us wiser in this issue. Because as such, structurally,
the last thing that you said, that an attached retina is much better than have that situation where we're trying to pull it upwards and creating situations for retinal surgeons subsequently.
Yeah, what I meant was that many times if you have an iridofungal coloboma with cataract, you do a cataract surgery. Many times there can be a shallow detachment behind, or there can be some retinal intervention, laser, etc., may be required. So for these, it is always one should prefer the comfort of the retina surgeon, what way he is comfortable, and then one should go ahead. And as you said that a patient is used to such a morphology, such an anatomic variation, the patient might be used to such anatomic variation. But as I said that a very intelligent patient will be able to let us know that whether with closure of that coloboma is helping him, is providing him better feeling. The second thing is that closure of coloboma has a very good outcome, should have a outcome in iris coloboma only. Iris coloboma only, then I think we should not leave that coloboma like that. We should make the pupil circular. And actually, I have that video edited also in laptop, but I did not show that. It was an iris coloboma. Just a few weeks back, I had operated iris coloboma only with cataract. Did surgery, put 3 such sutures, and made the pupil absolutely circular. It's looking very good. Hopefully, the patient should also.
Okay. So I think there are no more questions, and Dr. Rajesh has had a very hectic day. And
yeah.
so
And if I could just take one second or maybe 10 seconds.
Please, Bali. And
you see
after the Dr. Bali finishes, please. After Dr. Bali finishes his question, Navneet, can you be ready with the microvision video so that we don't waste time? Yeah, Dr. Bali, please go ahead.
Well, I'm exhorting everybody who's available, because all of us are all the panelists are cataract surgeons. December we're getting a special issue for manual small incision cataract surgery, and the last date for submission of articles is 30th of June. So please write your articles and send your articles on small incision cataract surgery if anybody is interested. Thank you so much, sir. I'm sorry I barged into that one.
The articles to be sent to you, or
no? The articles are to be sent, are to be submitted online. This is the special IGO issue.
IGO. Okay.
Yeah, this is actually Dr. Sinha is also heading the ISMSICS New Delhi chapter. I think we will be reaching out to you through the New Delhi chapter.
Definitely. We'll do it.
Are you going to review all the manuscripts?
So thank you, everyone. Thank you, Microvision. Thank you, Navneet, Mr. Ashok, Puneet, who have really been gracious to sponsor our video teaching programs. And this was, as has been the trend, our video teaching programs have been excellent. This thing in presentation, we have had stalwarts explaining the nuances of the series in which they are expert. Right, beginning from phacoemulsification, small incision cataract surgery, trabeculectomy, and today phacoemulsification in difficult and special situations. So thank you, Dr. Praful, Dr. Jatinder Bali, and of course, special thanks to Dr. Rajesh Sinha, who has been gracious enough, in spite of his busy schedule and his academic involvements at Udaipur. He's been kind enough to give us time and give this very wonderful presentation on phacoemulsification in different situations. And the things which we have not been able to see, like your phacoemulsification colobomata size in iris coloboma and iridofundal coloboma, and any more difficult situations, we will again invite you for part 2. and I hope you accede to our request. So thank you once again. Praful, you want to say anything? And Dr. Pawan is there?
I would personally like to thank you for giving me the opportunity, and of course, Praful, Dr. Bali, everyone, for giving me this opportunity to be a part of this wonderful program. And this is a wonderful initiative by you, and of course, our own Praful Marana is very, very active, and I really feel proud of him. So a big thanks to all of you. Thank you very much.
And Rajesh, you will be surprised that in spite of postgraduate examination in so many medical institutions, we have had very good attendance here also, YouTube.
Very nice.
And the best part of this video teaching session is that the residents are directly able to ask questions without hesitation to the stalwarts, and they can, because they always hesitate in asking in the scientific session in the various conferences whether they should ask or not. Here they get that privilege and opportunity to ask and resolve all their queries. And I think it's really wonderful. You have been very patiently explained all the queries of the residents from all across the country, whether it is from Calcutta, Bhubaneswar, and south and north part of our country. And before we end, I will again request that like we have been having the blockbuster weekends, we tomorrow have another DOS monthly meeting program at Gangaram Hospital. And we lined up excellent presentations by the faculty of Gangaram Hospital. We have clinical talk, we have mini symposium, and once again, we'll have the opportunity to listen to Dr. Rajesh Sinha for his guest case presentation. And of course, we have some good prizes also lined up, and this will be ended by, at the end, we'll have delicious cuisine provided by Delhi Che, and I'm sure none of you will like to miss it. Praful, anything? And doctor, after that, the last words by Dr. Pawan Goel, sir.
I think Pawan Goel, sir, is there.
I think he was busy, he had to go.
Sir, yeah. Can you conclude, sir? Thank you to all the panelists for joining. And this is the weekend time and you people are joining for a class. That's a great thing. Thank you, everyone.
Thank you. Dr. Bali? Are you there, Dr. Bali?
Left, I think. Dr. Bali.
I think he left.
Bali
okay. Thank you. Thank you. Thank you, everyone.
I just have to ask you one thing, if we can go offline.
Yeah.
Navneet, please stop.
Just
please stop. Huh?
Yeah, I'll